Hello everyone. Today I'm going to discuss about hyperemesis gravidarum. Hyperemesis. Hyper it means more, very much, something which is more than the normal, increased. Next is emesis. Emesis means vomiting. And gravidarum. Gravidarum is a gravid uterus. That's a pregnant woman. So hyperemesis gravidarum together, the term means increased amount of vomiting in a pregnant woman. Next, coming to the definition. Hyperemesis gravidarum is a pregnancy complication characterized by severe persistent nausea and vomiting that is more intense and frequent than the typical morning sickness. Now, nausea is a feeling of uneasiness or feeling of sickness or an urge to vomit, and vomiting is forceful, involuntary expulsion of stomach content. Now, morning sickness is very common in pregnancy. It generally starts from the first week of the first trimester and continues up to the end of the first trimester. In morning sickness, nausea and vomiting, both of them occurs, but it's very casual, general. But when this morning sickness it goes into severe and persistent, it is called hyperemesis gravidarum. Now there are clinically 3 points which are important. That first one is nausea and vomiting, severe. Weight loss, that is up to 25% of the body weight. Dehydration, which may also include electrolyte imbalance. Etiology, exact cause is unknown, but the following factors are expected to cause hyperemesis gravidarum. High level of HCG. HCG is human chorionic gonadotropin hormone that is generally increased during cases of twin pregnancy or hydatidiform mole. Next point is previous history of hyperemesis, young age, first pregnancy, which is very common, low body mass index, that is less than 18.5, and family history of hyperemesis gravidarum. And symptoms of hyperemesis gravidarum, first is pernicious vomiting, that is anything taken orally is rejected. Now since the person is not having anything and there is continuous vomiting, there will be poor appetite, poor nutritional intake. Since she is not having anything, nothing will go out, so reduced urine output. Again, since she is not having, there will be dehydration, there will be starvation. With starvation, there will be acidosis, there will be decrease in pH due to the stored fat is burning. Next, there is continuous vomiting, that is loss of HCl and hydrogen ions through vomitus, which will increase the pH in the stomach, causing alkalinity of the stomach. Now with all these things, the patient at the end is not having anything or having very reduced diet, so there will be body weight loss, that is 25% of the body weight loss. Now there is constant stress on the liver which may result in jaundice. The patient will feel weak with it. The vital signs will show rapid heart rate and low blood pressure. Now, aside all of this, there may be hemoconcentration with rising blood urea nitrogen and falling serum level of sodium, potassium and chloride. Now we will consider it as mild, condition as mild when there is loss of weight but no dehydration. The case is moderate when there is dehydration and circulatory changes. The case is severe when there are biochemical changes with complications like metabolic acidosis along with dehydration and loss of body weight. Investigation, first is urine analysis, biochemical or chemical changes, serum TSH, T3 and T4, ophthalmic examination and ECG. Urine analysis will do for quantity, color, smell, specific gravity, presence of acetone, protein or bile. Biochemical changes for sodium, potassium and chloride ions. Serum TSH, T3 we will do to rule out the presence of the level of TSH. Since hyperemesis gravidarum, it is caused due to HCG and estrogen hormone. Now this HCG during the first trimester, it mimics the thyroid stimulating hormone and results in overstimulation of thyroid. Therefore, to rule out the presence of gestational transient thyrotoxicosis, we will check serum TSH and then ophthalmic examination to rule out any retinal damage or retinal hemorrhage, since forceful repeated vomiting significantly increases intra-abdominal and intrathoracic pressure, which can cause valsalva retinopathy, which leads to rupturing of retinal capillaries. Next is ECG for potassium changes. Management. Medical management. Admit the patient to hospital. Keep NPO nil per oral for 24 hours or until vomiting stops. Give IV fluids and electrolytes to correct dehydration. Hypovolemia and electrolyte imbalance are corrected by administering intravenous fluid. Approximately 3 liters of fluid is infused in 24 hours, out of which half of the fluid is 5% dextrose and the other half is ringal lactate solution. Extra amount of crystalloids may be given or added to the amount of vomitus and urine in 24 hours. Now start NGT feeding if oral intake is not possible. Administer antiemetics like for example I've given here Phenergan 25 mg, Stemetil 5 mg, BD daily. Hydrocortisone 100 mg IV in case of hypotension or intractable vomiting. Now what is intractable vomiting? Intractable vomiting is severe and persistent vomiting which cannot be treated through standard medical treatment. And then in severe cases we also give prednisolone. Give steroids in severe cases, that is already covered, and provide vitamin supplements like B1, B6, B12 and vitamin C. Monitor electrolytes, urine output, ECG if potassium is abnormal. Next is nursing management. Encourage bed rest in quiet, comfortable room. Provide emotional support and counseling. After vomiting stops, start with small, frequent, bland diets. Like you can start with a chai, biscuit, or like chura, then dalia. Start with semi-solid and then go to solid food. Advice: avoiding fatty, spice, and preserved food. Monitor temperature, pulse, BP, weight, and intake output chart. Check urine for ketone, protein, and acetone. Educate the mother about hydration, diet, and follow up care. Next, we'll be discussing about the complications. The complications may include jaundice due to liver stress, circulatory changes because of dehydration, electrolyte imbalance. There may be tachycardia or hypotension or hemoconcentration. All of the 3 points have been discussed priorly. Next, third is retinal damage, Wernicke's encephalopathy because of vitamin B1 deficiency. Vitamin B1 deficiency will be occurring due to, first of all, there will be decreased intake of nutritional diet, and there is vitamin B is water soluble diet, so whatever vitamin was there has already been washed away. Next is Korsakoff syndrome, then is renal insufficiency, renal failure, delirium, coma, and at last death. Some nursing diagnosis I have written, that is ineffective airway clearance, anxiety related to pregnancy outcome, altered family coping, risk of aspiration, risk of fetal injury, and risk of infection. These are the nursing diagnoses that you can formulate for hyperemesis gravidarum. So, revising once again, hyperemesis gravidarum, it is characterized by severe persistent nausea and vomiting. The etiology is unknown but generally occurs due to high level of HCG hormone, previous history of hyperemesis, first pregnancy and family history. Sign and symptoms. The important sign and symptoms include pernicious vomiting, poor appetite, 25% body weight loss, dehydration, acidosis due to starvation, alkalosis. Due to HCl loss, there will be increased alkalinity, increased pH in the stomach, jaundice, low urine output, weakness, rapid HR and low BP. Investigation that will be done where urine analysis, biochemical and chemical changes where we check for blood electrolytes, serum TSH to rule out gestational transient thyrotoxicosis, then ophthalmic examination to check for any retinal hemorrhages, ECG in case of potassium decrease. Then management, medical management and nursing management. In medical management, you will admit the patient to hospital, keep NPO, give IV fluids and electrolytes, that is 3 liters approximately should be given within 24 hours, where half of the fluid should be 5% dextrose and the other half should be RL. In additional, we can give the amount of we'll calculate the amount of urine and vomiting that is been passed, and that amount of extra crystalloids may be given to the patient, and antiemetics like phenergan 25 mg temative may be administered, and in cases of hypotension, hydrocot 100 IV or prednisolone in severe cases, then vitamin supplements, and will monitor the electrolytes, urine output, and ECG. In nursing management, encourage bed rest, provide emotional support. Then, as like we do not just go to diet, no, we start from semi-solid, then to solid, liquid, semi-solid, and solid. Avoid fatty, spicy food. Monitor temperature, pulse, BP, weight, and intake output chart. Check for urine or ketones, protein and acetone. Educate the mother about hydration, diet, and follow-up care. Next, with the complications. Then we'll go to nurse repeated NORCET facts. These are the questions that has been come on NORCET. The first one is most important hormone which is important in hyperemesis gravidarum, which causes hyperemesis gravidarum, is HCG. Now, I have already told this HCG hormone, it mimics TSH, as a result of which it causes overstimulation of thyroid hormone, resulting in gestational transient thyrotoxicosis. Most common urine finding is ketone in urea, because the stored fat will be breaking down and ketone production will take place, resulting in ketone body formation. Most common complication is dehydration with electrolyte imbalance. And vitamin that is given glucose is thiamine. Most dangerous neurological complication is Wernicke's encephalopathy. The question comes, weight loss in hyperemesis gravidarum. Now you see, weight loss will be 5% of pre-pregnancy weight or 25% of present body weight. So this is it with the topic. Thank you everyone. If you have any doubts, any questions, or want to give any feedback, you may comment down below.